Ready to go? Yeah.
Yep. Okay. All right. You tell me, Ellen.
Yeah, ready to go. You're on stage.
Okay. Hi. Very good afternoon to all of you and a happy new year. This is 2022 and it's time for our grand round. This is grand round number 15 and for today we'll be talking about a very common problem, varicose veins and ulcers. And with me, I have Dr. Liu Ngo Chin, vascular surgeon at Subang Jaya Medical Center, and Dr. Navin Sukilan, a cardiologist at SJMC. So, visuals again, usual format, have a question and answer sessions, and I shall start with a very simple problem, unilateral leg edema. What are causes of unilateral leg edema, Dr. Navin?
Hi, Vijaya. A very good afternoon to our audience. It's an honor to be here today, co-chairing this session with Dr. Liu. Iron. Sorry. Okay, so I guess you missed what I said just now. Good afternoon, everyone. It's an honor to be here today, co-chairing this session with Dr. Liu. Ironically, Dr. Liu taught me everything about varicose veins back in medical school 20 years ago. And so now today we are co-chairing a session. So back to the question, what are the causes of unilateral leg edema? So basically, unilateral leg edema is usually due to peripheral or surgical causes. This could include venous disease such as deep vein thrombosis, varicose vein, which we're discussing today, lymphatic disease, mainly lymphedema, and also another cause is arteriovenous disease such as AV fistulas. And I mean, just to add on, bilateral causes are usually due to medical or central causes. This could include renal failure, nephrotic syndrome, liver cirrhosis, and of course, heart failure.
Mentioned about lymphedema and chronic venous insufficiency. Is there any way we can distinguish between the two clinically?
Well, there is a simple bedside test that we can do. It's called a stemmer's sign, which whereby we actually pinch the skin at the base of the toe. If this is difficult or even impossible, then you have a positive stemmer sign. And a positive stemmer sign is basically a reliable diagnostic test to recognize lymphedema. And the other thing that we can actually notice is patients who have lymphedema will have deeper natural skin folds over the joints, swelling over the backs of the hands and feet, and taut skin. And these are actually basically signs that indicate the patient is having lymphedema.
Now, these are very common that we see in a lot of our patients. What is this? And is it abnormal, Dr. Navin?
Okay, so this is basically called corona phlebectasia. They are basically normal. They are just larger than healthy capillaries. So I think besides causing a cosmetic issues, they are fairly normal variant.
And then we have which women get very worked up about. Are these abnormal?
Well, the first picture, I think you can see those are just superficial veins. Probably you can see it quite obvious in those who have thin or fair skinned. And the second picture that appears to be spider veins. So spider veins, I think again is more of a cosmetic issue.
Okay. All right. Why do people develop varicose veins? What are some predisposing causes, Dr. Navin?
Okay, so basically we know that varicose veins are enlarged and twisted veins, right? And what are the predisposing factors? This could include age. The incidence increases with age. It's more common in women due to hormonal changes, mainly during pregnancy and menopause. Also very common due to obesity. And the other thing is long hours of standing and sitting. Certain occupational groups such as doctors are prone to this, especially surgeons, school teachers. Yeah.
Dr. Liu, you said you taught Navin. I remember I was also taught about this Trendelenburg's test and Perthes test. Is there still a role for the simple bedside test and what are these? Dr. Liu.
Yeah, hi, good afternoon. The Trendelenburg test is actually a very simple test where we tie a tourniquet at the saphenofemoral junction and then we ask the patient to stand up And so if all the varicosities disappear, bingo, we got the diagnosis is the saphenofemoral junction incompetence. But if all the varices remain as it is, it could be due to saphenopopliteal junction incompetence, or it could be due to some thigh perforated incompetence. And Trendelenburg test has withstood the test of time compared to the other tests. And I think it's a very simple test for us to look at this varicose veins, whether the incompetence is at the saphenofemoral junction or elsewhere. So I think it's still a very useful test. Now, when it comes to Pertis test, this test actually is to make sure when the patient has got these varicose veins, it's not due to the obstruction of the deep vein system. And so what happened is, you can imagine that you've got enlarged varicose veins, and then now you tie a tourniquet over the thigh, you ask the patient to exercise, and then patient traditionally will have a bursting kind of pain over the calf because you are occluding the superficial system and your deep system is already occluded. So meaning that now when you exercise, more blood going down to the foot, but nothing's going back, and so you can get a bursting kind of pain. Now, having said that, Pertis test is really quite obsolete because we all know that some of these deep vein thrombosis do actually recanalize, and so Pertis test may be negative. So as of today, very rarely we do this Pertis test.
Can you explain now, then? Now, before that, can you please take us through the venous drainage system of the leg, Dr. Liu? Just
Yeah, so basically there are two systems of vein. One is the superficial vein. As you can see, the great saphenous vein drains all the way from the foot to the medial aspect of the leg to the medial aspect of the thigh and goes into the saphenofemoral junction. There's another system of vein, we call it the short saphenous system, that drain mainly posterior and the lateral aspect of the calf vein and drains into saphenopopliteal junction. And the other system is actually deep veins. So when you have a deep vein, it's actually, this deep veins runs corresponding to your artery. So you got superficial femoral vein, and then you got tibial veins, etc. It's important for us to understand these two systems because sometimes when patient come to me for venous stripping, and the patient will ask a question, if you strip out the superficial vein, then how's the blood going to return to the heart? So remember that you strip out superficial vein, the blood can still return to the heart through the deep system.
You mentioned that some of the tests that we have been taught are now obsolete. So what diagnostic tests do you normally do to diagnose varicose veins, Dr. Liu?
I say Pertis test is not done, but Trendelenburg test is still very useful. Now, you imagine if you were to be in the Gua Musang and you have a patient that come to you with an ulcer, and then when you do a Trendelenburg test, you find Trendelenburg test is positive. And so it's quite safe for you to go on to do a high ligation, stripping of vein, and that ulcer will heal. So in the kampong setting or in a village setting, I think you don't have the use of duplex scan. I think this Trendelenburg test is in a way still useful. However, in larger cities, you find that ultrasound is very widespread. You can get an ultrasound easily. And so right now, the gold standard is actually a duplex scan. So duplex scan, duplex sounded like double. So it's a combination of a B mode scan, which is the usual ultrasound scan we see, plus a Doppler. So you combine these two together, you can actually see the incompetence in the vein. We can actually measure the reflux time. And so it's a very useful test. Yeah.
Now, is this varicose veins purely a cosmetic problem, Dr. Navin? Are there any health concerns due to these veins?
Well, I mean, no doubt that the varicose veins are a cosmetic issue, but there are genuine health concerns. And some of the things could include pain, right? You can actually cause pain, a kind of a dull, aching sensation. The veins can actually get thrombosed, and that again can cause a lot of complications. You can actually have bleeding, ulceration, and also inflammation of those veins, what we call thrombophlebitis. So these are some of the health concerns due to varicose veins.
Is the presence of varicose veins a risk factor for the development of DVT, or is there any connection between the two?
That's a very interesting question. Because when you have got varicose veins, it is a risk factor of developing deep vein thrombosis. we all know if you have got superficial vein incompetence, there's a lot of reflux in the vein. And so when the blood goes up, it goes into the deep system. And so when the deep system get overloaded, you find that there is even a deep vein incompetence. So the veins get very dilated. And because of this reason, when you look at the risk factors for DVT, varicose vein, it is a risk factor for DVT. Now, having said that, I have many patients who actually fly all over the world with varicose veins. They come to see me. They want this varicose vein removed. Hopefully, they can remove risk factor. But there are no studies to show that even after ablating your superficial vein, the risk factor for DVT is reduced. So yes, varicose vein is a risk factor for DVT, and ablating a superficial vein doesn't mean that you will reduce the incidence of DVT.
Person has a varicose vein, does she need to take prophylaxis against DVT on long-haul flights? Dr. Liu?
Yeah, we heard about this economy class syndrome, especially for people on long-haul flights, meaning flights that's more than 5 to 6 hours. So normally, if you have to fly to Dubai about 6 hours, or you have to fly to Shanghai about 6 hours, that's still at the borderline. But you have to go higher than that. You have to go to Europe, you go to America, then the risk is a bit higher. So if you have got no family history of deep vein thrombosis or no previous history of deep vein thrombosis, perhaps I would advise that you wear some kind of a compressive stocking. And this stocking has been named as a travel stocking. And they comes in different colors. You can get pink stocking, white stocking, blue stocking, etc. It's actually quite colorful. But if you have had a history of a deep vein thrombosis, then it's a different matter. In that case, I would advise that perhaps you want to take a dose of a low molecular heparin before you travel.
So what prophylaxis would you give? Low molecular weight heparin, aspirin? Is there a role for aspirin? Dr. Liu?
Well, the aspirin is mainly, as you know, is an antiplatelet rather than an antithrombotic. So normally we don't recommend an antiplatelet. So the least you can do is put a patient on the jab of a low molecular weight, such as a prophylactic dose, say at 40 milligram. I don't know if there are some studies that look at this DOACs, the direct oral anticoagulant, whether they also exert the same effect. This is something we need to look up.
Thank you. So what is the CEP classification, Dr. Liu? You often hear about this.
Now, CEP is an acronym for C stands for clinical, E stands for etiologic, A stands for anatomical, P stands for pathophysiological. So basically, when you use a CEAP classification, you will be able to describe varicose veins better. In the sense that clinical, you can classify into 6 grades. The worst are those with venous ulcer, C6. And those C1 are those small telangiectasia or reticular vein. So that's on clinical classification. And by and large, we use mostly clinical classification. Etiologic, it mainly refers to whether this is due to primary or due to secondary. So you can develop, say, varicose vein secondary to arterial venous fistula, or you can develop a varicose vein secondary to some previous DVT, etc. Anatomic, I think, is important because we want to know where the reflux comes from. Does it come from saphenofemoral junction, saphenopoplar junction, or cuff vein perforator? That's the anatomic. So pathophysiologic, it basically tells us whether this varicose vein is formed because of occlusion or is it due to reflux, because the treatment of both are quite different. So this is actually a very useful classification. But of all this classification, the most useful for us to categorize varicose veins is still the C, the clinical classification. Where C0, no varicose vein, C1 is reticular vein, C2 are those varicose veins. So most of the time, people have got C2 when they come to see us. Sometimes with a bit of edema, that becomes a C3. And then C4 are those with skin changes, C5 is those with ulcer that has healed, and C6 are those with active ulcer.
Atrophy, Blanche, and the lipodermatosclerosis. Okay, what advice can you give the person to prevent these veins from getting worse, Dr. Navin?
All right, so before you get
before you get a consult with Dr. Liu, a few simple things you can try. One is exercise regularly, lose weight if you're overweight, avoid standing or sitting for very long hours, and if you have to, you can't avoid, then in between try to put your feet up. Don't wear very tight fitting clothes. You can also try support or compression stockings, and for ladies to avoid high heels. So these are some simple things that you can actually do.
What minimally invasive options are there for treating varicose veins, Dr. Liu?
Before I answer this question, I think I need to add on to what Naveen said just now, because this is a very common question people ask. What can you do to prevent progression of a varicose veins? There's a study, we call it the Edinburgh vein study. They look at the cohort patients, follow up over a period of time. And interestingly, some of these patients were followed up for a mean time of 12.5 years. That's a very long time. So they have a subgroup of patients that they follow up for a long time. And they realized that up to 50% of these varicose veins, they actually progress. They then did a sub-analysis of those who actually progress. And it's not surprising, those with a family history of varicose veins, they are likely to progress. And those who are obese, they are likely to progress. And those who actually develop deep vein thrombosis, these veins are likely to progress. So based on all this data, we actually advise the patient that a couple of things you can do. What Naveen pointed out correctly, don't get too obese, do regular exercises. There's nothing you can do about family history because you just have to accept it. And so I think keeping yourself fit, wearing stocking, do exercises, I think this can actually actually delay the progress of varicose veins. So what are the minimal options that's available? Well, in the past, for varicose veins, if we find that it's due to axial reflux, meaning that it's a reflux at saphenofemoral junction or saphenopoplar junction, we go on to ablate the superficial vein. So we can actually do a high ligation strip of the vein. But these days is very modern. Many of these can be done as an outpatient basis. We send the patient for endovenous laser, or you can do a radiofrequency ablation. And we are able even to put in some glue to glue up the vein. And also sometimes we just inject some sclerosant. The advantages of this minimally invasive option is you now no longer tell the patient that you're going to do varicose vein surgery. It's classified as a varicose vein ablation procedure. And in the past, varicose vein has always been a realm of surgeons. But right now, with all this minimally invasive procedure, it is now everybody's business. So there are a lot of GP clinic, aesthetic clinic, and all that. Once they master the skill of ultrasound, they are able to do many of this procedure as an outpatient basis.
What are the costs like? Are we talking about? We're talking about, say, a laser, endovascular laser, something like that. How much ballpark figure, roughly?
All right. So if you were to come in for an open vein surgery, meaning that you need to stay in hospital for 1 or 2 days, you need a general anesthesia, a spinal anesthesia, and these days our anesthetists are very careful. They make sure that your ECG is normal, your blood tests are normal, your heart is not too bad, your chest X-ray is clear before they do it. So despite 2 days hospital stay and all that, it will cost you about 12,000. Now, minimal invasive took away hospital stay, took away all this what you call pre-operative investigation, anesthetic costs, etc. However, you need to pay for all this radiofrequency and a laser, etc. There's actually a cost, And in places like Sime Darby Medical Center, where they follow JCI, single use, everything else is thrown away. And you'll be surprised that minimally invasive and maximally invasive, the price is the same. It also costs about 10 to 12,000.
Sclerotherapy, is that cheaper?
Yes. Sclerotherapy certainly is much cheaper. In fact, sclerotherapy has got the advantages as you can do it in the outpatient clinic, However, sclerotherapy, sometimes you have to do multiple sessions because one session may not ablate all the veins, so you have to do multiple sessions. So at the end of the day, the cost may add up a bit cheaper, but the efficacy in terms of if you compare surgery, endovenous laser, radiofrequency, glue, I think the efficacy of these three are much better than sclerotherapy.
Also be done as outpatient?
Yes, glue is done as outpatient. In fact, glue is quite useful for people who are a bit obese. You know, sometimes you find that it's quite difficult to assess the junction, so you just put in the glue. So the glue actually seals off the vein, superficial vein, so it prevents this reflux from coming down. However, as a caveat, the glue is actually a foreign body. They recognize that, and so we are not sure. If you were to take out the vein, you burn off the vein, etc. You're actually doing you leave nothing behind. But glue, now you're introducing something into the body. Whether this glue in the long term will give rise to some kind of delayed allergic reaction, we are not quite sure. But for time being, based on the literature, the glue is quite safe.
Is just ligation and removal, is that correct? Or are there any other surgical options?
No, basically you're quite right. It's actually high ligation, stripping, and ligation of perforator and multiple step abortions.
This is the first case. It's a 55-year-old man, Dr. Liu Mo-chin's case, presented with left leg swelling, itchiness, and discoloration of 6 months. He actually went to see the dermatologist, and because he's not getting better, someone asked him to come and see the vascular doctor. He's got diabetes and high blood pressure, and he's on dimecron MR, glucophage, atorvastatin, and amlodipine. On the left leg, you can see is swollen. It's pigmented all the way up, but the area of foot is spared. Dry, scaly skin, and the left leg is slightly bigger than the right leg, and all the pulses are palpable. Okay, is this pigmentation due to any of his medications, Dr. Navin? He's on dimecron, glucophage, atorvastatin, and amlodipine.
Very common drugs that we use in our practice, and none of those drugs are actually associated with hyperpigmentation. Amlodipine may cause a bit of leg swelling, but usually that's bilateral as well. So I don't attribute this to any of his medications.
Significance of this?
Well, this is a very interesting case. This is quite a middle-aged man who's a manager, and who came with this very irritating symptoms of left leg swelling and also the pigmentation. So, you know, with this pigmentation, he can't wear shorts. He can't go jogging with shorts, and he's got a lot of itchiness, and he has been applying all sorts of creams on the leg. And so when I first saw him, I'm not quite sure whether this is some kind of a problem with pigmentation disorder, or maybe patient has got some kind of reflux of these veins. As you know, when you get a reflux of blood down incompetent vein, over a period of time, the blood cells actually get out from the vein, the venous, and go into subcutaneous tissue. And so when the red cells break down, they actually deposit this hemosiderin pigmentation. And for cases like this, can we go back to the last slide, the previous slide? Yeah. So for cases like this, normally the pigmentation is maximal around the gaiter area, especially around the ankle. And you'll be surprised that venous disease, when ulcer occurs, often occur at the medial malleolus and lateral malleolus, and maybe sometimes anterior aspect of shin. They almost never go down to the foot. So looking at this, to me, it could be due to venous disease based on a couple of things. Number one, the sparing of the foot, and then the maximum pigmentations around the ankle. In fact, the history is the pigmentation ascend from ankle, it goes up to the lower third of the leg, and then ascends slowly up to the knee. And so that together with the leg swelling made me think perhaps it has something to do with pigmentation of a varicose vein. And this patient is more concerned about the cosmetic appearance because he finds this is horrendous. You know, once he takes out his trousers, he finds that the whole leg looks quite grotesque. So I thought perhaps it has to do with his varicose veins, even though I can't see obvious varicose veins in him.
What's the cause of the skin pigmentation in chronic venous insufficiency, Dr. Liu?
Yeah, so we all now understand better of this chronic venous disease because we know it's due to a venous hypertension. It could be due to the deep vein obstruction, or it could be due to this reflux. When there's venous hypertension, you find that due to this venous hypertension, some of these red cells actually migrate into this subcutaneous tissue. And so these red cells break down and then give rise to a lot of this hemosiderin pigmentation. Now, the white cells are it migrate out of this blood vessel. And right now, the theory is the white cells that release these inflammatory mediators that causes all this inflammation and ulceration, etc. So in this case, very likely, this pigmentation is actually due to hemosiderin pigmentation. And this man was very adamant that if I want to do anything, he asked me, will this pigmentation go away? That's the main thing. But for a case like this, I wasn't quite sure whether I'll be able to remove this. But certainly, I believe that by doing this varicose vein surgery, I will be able to relieve him at least of the swelling and of the itchiness. So
you want to say something, Dr. Liu, about this?
Yes. So this is taken from some of this brochure issued by the health department in UK, in the National Health Service. So I'm sure this is something very common, hemosiderin pigmentation, reddish brown staining above the ankle. I think if you are Caucasian, you are very fair, we can see this very, very common. And so these changes, people are very concerned whether this is something serious or not. And so this NHS brochure to tell them that this is due to hemosiderin pigmentation, that you perhaps has got some chronic venous disease. Can you go on to the next slide? So they advise that you should consult a GP and let the GP ascertain that this pigmentation, it is indeed due to this varicose veins and not something else. What is the something else? The something else we refer to things like psoriasis can also cause pigmentation, or sometimes there could be some eczema, there could be some thrombophlebitis can cause all these things. And then the treatment, they ask moisturizer, compression, and exercise.
So what did you do to your patient, Dr. Liu? Maybe you can tell us.
Okay, for this patient, I was quite convinced on clinical examination that he's got some chronic venous disease. Can you play the video here? Sorry. Yeah, you can see the venous flow here in the great saphenous vein. And you find that this blue color actually turns red, indicating there's actually a venous reflux. Next slide, please. Next slide, please. Yeah, so you can see that at the saphenous junction, normal flow into the vein is blue in color. And when the patient does a Valsalva, the color becomes red, indicating the flow is into the opposite direction. The same thing in the great saphenous vein. You find that normal flow is blue in color. When the patient does a Valsalva, it becomes red in color. So there's actually a reflux in the varicose veins. Next slide, please. So we can also record it on duplex scan that show there's actually a significant reflux. Okay, next slide. Okay, sorry, this is my operative note. So in this man, I'll not do a laser for him because I just want to be sure that it is the veins that cause the problem. And also I want to be able to ligate most of the branches of this vein. And so I did an open surgery for him. And I only kept myself to the thigh. I didn't go all the way to the leg because the area looks like a jungle area. And he underwent a high ligation and stripping of the great saphenous vein up to the knee. Next slide, please. And this is on follow-up. You find that there's actually clearing. About 3 months, the thing actually becomes better. And he did tell me that now the pigmentation is going down now. So this is about 6 months. Next slide, please. So over a period of time, you find that the leg actually became better. So this is initial presentation and this later presentation. So it does show that, in a way, it does prove the theory that this is due to hemosiderin pigmentation, because the body is able to reabsorb the what you call the hemosiderin, and so this is actually due to a reflux in the veins.
Okay, we move on to our second case. A 77-year-old lady, ex-construction worker, who had a right leg ulcer for 10 days, very, very painful, and she has bled from the ulcer twice during showering. She had bilateral total knee replacement 10 years ago, no other chronic medical illnesses. So how can you distinguish between an arterial ulcer and a varicose ulcer, Dr. Liu?
Maybe I should ask this to Naveen, because this is a...
To answer that, or you want to ask your boss?
Well, let me recall what I remember from 20 years ago. Okay, so I think one is the location, right? You also mentioned that the varicose ulcers are usually at over the medial malleolus. That's one thing. And then, of course, a simple clinical examination. Arterial ulcer, you have to check the peripheral pulses, make sure that they're all present. If the patient doesn't have good peripheral pulses, then probably has underlying peripheral vascular disease. So those are, I think, some of the most common distinguishing factors. Anything that Dr. Liu wants to add on?
No, I think Naveen's a very distinguished student. So all that he says is correct.
Okay. You want to take over about the examination and also Dr. Liu?
Yes, I mean, typically when we teach the students ulcer, even in the third year, they are supposed to be able to distinguish between arterial or ischemic ulcer versus a venous ulcer. A venous ulcer occurs in the gaiter area, and also there's surrounding a pigmentation of the skin. And in this lady, it's obvious there's actually a lot of varicose veins, a telltale sign. And she's a hard laborer. All her pulses are actually palpable. This is a very interesting lady. She actually came from Penang all the way to stay with her daughter because she's got ulcer, a lot of pain, she can't sleep, and daughter stays in Kuala Lumpur. And so she's quite a tough lady that came in. And then the daughter told me that she has not been sleeping. And so this ulcer is very, very painful. And so that also dispelled the myth that venous ulcer is painless. No, venous ulcer can be painful. And some of my patients tell me that when they switch on the fan, they can actually feel the pain increasing. So we used to think that this is actually a myth, but it is true. Because underneath this venous ulcer is actually a periosteum. And periosteum, it's sensitive even to humidity, to changes in pressure, to air current, etc. So they are very sensitive. So looking at this, I was very convinced that this lady has got a venous ulcer. This is CAP class 6, and this is due to this reflux in the superficial vein. And I'm very sure it's due to superficial vein because I can see the vein at the same time. You find it compared to both lower limb, the legs isn't very swollen. So I think it's mainly due to the superficial vein problem.
So you want to take us through this, Dr. Liu?
Yes, so actually we did a duplex scan. Again, this is the sacrophumoral junction. When the patient, this is a normal flow, blue in color. When the patient does a valsalva, then you can see that there's a reflux in flow in the opposite direction. So definitely there's something wrong with sacrophumoral junction. Next slide, please. Yeah, so just to show you in the duplex scan, it's very simple. You can actually measure a forward flow, and when you ask the patient to do a valsalva, it's forced expiration against a closed glottis, you find that there's actually reversal of flow. And reversal of flow, anything more than 0.5 seconds is considered significant. But in this case, it has gone on for at least 4 or 5 seconds. So I'm very convinced that this is due to a problem with the vein, due to reflux in superficial vein. And so in this patient, I schedule her for a high ligation, stripping the great saphenous vein. I mark out all these veins so that I can strip out the vein. But more important than that is normally around this ulcer, there's actually a perforator that come out from the deep vein. So this is intraoperatively. I'm wearing OT clothes, so she put her leg, foot resting on my thigh. So I need to catch the perforator. And I got the perforator, it's a very significant perforator here. And then I subjected this patient to, to venous surgery. Now you ask me, can I subject her to laser therapy, to radiofrequency, glue ablation? Yes, all these modalities can be done. But for this lady, I think she's a tough lady. She isn't concerned about her cosmetic appearance. RFA laser all has got maybe a bit advantage in cosmetic appearance. All that she wants to do is she's able to sleep and the ulcer heals. And so that's a key point. So I took on the surgery. There are many things you can do about this perforator sound, and even do injection, etc. But I think I just go straight for surgery. This is at the groin, at the saphenofemoral junction. Just to describe to you, this is actually a black silk suture pulling on the great saphenous vein. And this one is actually the saphenofemoral junction. I've actually tied all the branches, small branches. And so in this next slide, I actually divided the great saphenous vein from the common femoral vein. So I ligated this vein and then I strip off the vein. Next slide, please. So this is what I did. This is my operative note. There's a huge perforator there, this varicose ulcer. This actually is saphenofemoral junction incompetence. And so I did a high ligation stripping of the vein. And this small vein bleb you can see is actually the perforator. It's just about 2 cm above the ulcer. So this is the thing that I cut it off. Next slide, please. And so this is what we do. We put in a stripper. You just pull it up so it becomes like a kebab. So incision is very small. You do maybe about 2 centimeter incision at groin, maybe about 1.5 cm incision somewhere at the thigh, and then another incision where you get a perforator. It's a tiny incision. And then you use this stripper to pull up the vein. So this is what we call by stripping. Next slide, please. All right, just to show you, this patient came back for follow-up 1 week later. The ulcer has healed. So once you get the diagnosis correct, the ulcer will heal. And this, I haven't even taken out this dressing set. This is all the step avulsion wound and all that. Yeah. So this ulcer is healed. You go on to the next slide, please. And she has gone back to Penang. Now you find that the ulcer is healed. This is about three months. The ulcer is completely healed. And this lady is quite smart. She knows that she's got also contralateral saphenofemoral junction incompetence. And so she actually now decided to put on stocking before an ulcer occurs. So I think this has if you get the diagnosis correct, sometimes it's very rewarding when the patient come back. They're actually painless. The ulcer is healed.
All right, you would like to take us through the key messages or the learning points from these 2 cases, Dr. Liu?
Yeah, I think chronic venous disease is something very common. In fact, initially we actually have a slide that look at leg edema. As a patient presented with a bilateral leg edema, but that slide has been taken out. I think that's a very important message, that when you see a patient with bilateral leg edema, you need to first of all rule out a systemic cause, such as those with heart failure, kidney failure, and maybe hypoalbuminemia. But by and large, many patients sent to my clinic with bilateral leg swelling. They're actually from old folks home, etc. And one component of leg swelling which is not talked about is actually due to this venous disease. And so if you are active, you're walking and all that, you find that your calf pump actually pumps the blood up. But if you have some problem with the ankle, there's a ankle joints arthritis, or you put the old folk, I say in the old folks home, what they do is in the morning they wake the patient up, shower them, and then put them in a wheelchair, and they sit until maybe 3 or 4 p.m. the whole day sitting down, not moving, and the leg will be swollen. So the commonest cause of a bilateral leg swelling in the old folk, especially staying in the old folks home, actually due to stasis. So I have many patients that come to me. They are perfectly okay, not due to DVT. They don't have failure and all that. It's actually just due to stasis. And I see a lot of young people that come to me during lockdown. They also have bilateral leg edema. It's basically because they are sitting in front of this computer, either watching movie or what, they are not moving at all. And so that causes a lot of this leg swelling. So important, we need a healthy joint, we need to have a muscle cuff for this pumping, and then we need a healthy vein. So that's prevent the leg swelling. So the chronic venous disease spectrum, there could be just spider vein, telangiectasia, etc. It could be hardened pigmented skin or something that can go to ulceration. And I think Naveen has described to us that patients with telangiectasia, mainly due to cosmetic reasons, but not really true. Some of them with telangiectasia, they do have pain. So for a long time, people are trying to explain why is it that it seems the size of the vein is not corresponding to symptoms. Some people very little vein, a lot of symptoms. Some people with big vein and yet they have no symptoms. And so what we found was sometimes you may have some telangiectasia over certain areas, say behind your knee, and some of these telangiectasia could be actually distending on one of these little nerve fibers. And surprisingly, sometimes by injecting these veins, the pain disappears. So they think it's actually due to this distension of these nerve fibers or inflammation, these nerve fibers that causes this pain. So it does not mean that telangiectasia, you have no pain. And what about those with huge varicose veins? They come to clinic, they are perfectly okay with it. They are not bothered about cosmesis. Why is this so? And I feel it's because body has got a compensatory mechanism. Because you may have huge varicose vein, a lot of reflux, you have no symptoms. Why? Because these people are still very active. So you find a lot of these farmers, they are walking around up and down. There's no problem. Huge varicose veins, they are fine. They say got no pain. They are quite honest about it. There's no pain. However, at some stage in their life, when they slow down due to some intercurrent illness, that's where the problem begins because your body is not able to compensate. Well, the third point is duplex scan is the main diagnostic modality. Duplex scan is widely available, and for GPs and all that, I would advise you to also try to get the duplex scan, because these days of a stethoscope alone and clinical examination alone is overtaken by technology. And many a times you can have a duplex scan by just buying a probe. You know, you can go to Alibaba or one of these, whatever, you can buy a probe that costs you maybe $1,000, $2,000 US. It's available now. And then you download a program, and that you can use a probe link onto your handphone. You can actually use it as an ultrasound. And all that you know is just to learn the technology. So when I teach the students, I told them that you want to be a GP, want to be a village doctor, it's always good to learn some new technology, but things are very available. Then they say, no, duplex scan is very expensive. Yes, duplex scan is very expensive. A good duplex scan, ultrasound will cost you maybe 100,000, but the device is getting smaller and smaller. So these days, maybe 1,000 ringgit, which is cheaper than a handphone. Remember, your handphones probably cost much more than a duplex scan, and can wear it over your pocket, and you can use got a diagnostic modality available. And these days, venous disease, the pathophysiology is very clearly elucidated. We can see the reflux. We can know where the problem is, and we can actually treat the whatever problem very well. So the treatment modality include medical therapy, compression, and also some vein ablation. With that, I think that finished the topic on chronic venous disease. Jaya.
Thank you very much, Dr. Liu and Dr. Naveen. It was short, sweet, and now we're looking forward to questions from the floor. Back to you, Alan.
There's one question from Sunita. What about insurance coverage?
What about insurance coverage? Dr. Liu, would you like to take the question?
Yes, when you have a venous disease, insurance cover it, but again, when it comes to insurance, the insurance will ask, is this patient coming in mainly for cosmetic reasons? If this is cosmetic reason, then insurance do not cover. So most of the time you ask the patient, why do you come in? And if the patient says, I have a pain, then again, like I say, it could be a very tiny vein and all that. The pain is actually genuine. And so when you put down there as symptomatic varicose veins, yes, the insurance cover. But if you, you do not have any symptoms, basically you don't like your vein, you want the leg to look better, you want to wear hot pants or short skirts, then I'm sorry, insurance do not cover.
Any other questions that from the floor? Okay, so it's not only the people in the old folks' home that do not walk and get bilateral leg edema. I think we have seen a lot of our elderly patients, both men and women, who are brought in because of bilateral leg swelling. Hey, doctor, is it because of heart failure? And almost always is due to stasis. Is there any, I mean, these people cannot walk. Is there any other way that you can advise how they can treat their bilateral leg swelling, Dr. Liu?
Yeah, I've got this good friend who stays in Texas. His name's Ingemar Davidson. He does a lot of papers, and he tells me, he's a retired man, not old, he's retired, and he sits in front of a computer maybe for maybe 12 hours a day, and he writes his book and all this, doing papers and all that. And he says he put on what they call his alarm. Every 2 hours, the alarm will ring, and he will get up. He walk upstairs, downstairs, couple of rounds, and then another 2 hours he'll do that repeatedly, and maybe sometime just before lunch he ring again, then he goes to the gym. So I think it's very important that people remember they need to get up and start walking to actually prevent stasis, because sometimes when we sit in front of a computer playing computer game, it could be maybe 12 hours, could be 24 hours. And so the other important thing that for us to realize is that you need not necessarily you need to walk for the blood to flow. It has been shown that in our soul, there's actually a venous, they call it the plantar venous plexus. By standing up, putting your weight on the soul itself, that will elicit a gush of blood up to your heart. And in fact, sometimes people undergo orthopedic procedures like total knee replacement, etc. They put on a foot pump, not a calf pump, a foot pump. So it actually compresses in the soul, and that is enough for the blood to flow. So I think it's very important that for us, even for old folks, you at least try to get them up and try to help them to stand up and maybe walk a bit, and then later on you can sit down. I think that will help. But for those who really you can't, they are bedridden and all that, then the other things you actually put them on some kind of a massage, regular massage, a limb physio, moving the joints. That also will try to contract the muscle a bit, and I think that's very important. Besides that, also prevent bed sore.
Yeah, but Deflon.
What's the role?
Okay, so before I speak on Deflon, I need to have my disclosure. I'm also one of the speaker for Deflon, but nevertheless, I need to be able to say that there are not many venotropics, something that can actually help in the venous circulation, and Deflon is one of them. And it's actually, they call it one of these flavonoids. It's classified under flavonoids. So to be able to understand how Deflon works, we need to first of all understand how people with varicose veins suffer from these varicose symptoms. Like I mentioned to you just now, many of these varicose vein symptoms are actually due to the white cell. It's the white cell that actually gets forced out from the capillary, and this white cell release some kind of inflammatory mediators that causes this discomfort. And so Deflon has been shown that they're able to actually decrease this release of these mediators from this white cell, and that can actually improve your symptoms. Now, having said that, I also need to clarify. Now, if you have, say, a varicose veins with a lot of reflux, Deflon has been shown in this major study, they call relief study, worldwide study. I was participant of this study, and they are able to relieve symptoms of itchiness, symptoms of pain, distension, and also decreased swelling. But Deflon does nothing to the veins, in the sense that it does not decrease the vein size. So imagine varicose vein is a mechanical problem. You stand up, the veins are big, you get the symptoms. But these symptoms are decreased by Deflon. But Deflon do not ablate the vein. So maybe you got small vein, maybe you can use Deflon, but if you got big vein, perhaps you also need to think of this some kind of surgery.
For Dr. Liu, people use compression socks or compression stockings. You too mentioned it. Can they use it even when they sleep? Dr. Liu?
Naveen, you want to answer the question?
I think I'll pass this one to you. I'm not too sure as myself.
Okay, it's a this question is quite close to my heart. Now, when you are standing, you can imagine that your valve is deficient, and so there are no valve in the inferior vena cava. There are some valve in the iliac vein, but most of the valve starts from below the inguinal ligament. So when you're lying supine, your right atrium and your ankle is about in the same level. So by wearing stocking, it does not help. But if you are in the erect posture, your heart is here, your legs down there. By wearing this stocking, it actually prevents reflux and also leg swelling. So stockings are usually worn when you are standing for a long time or when you're walking. But when you're lying down, actually there's no effect at all. And sometimes you find that we advise patients to put 5 pillow, or sometimes they even put the bed up, the foot end of the bed. I don't know how they are going to sleep like that because they might slide down on the head end. And to me, that is actually that is not science. Basically, once you're supine, your leg and your right atrium is in the same level, so there's no more reflux. So even you put your leg, by yoga, your head down, leg up also, it does not make any difference because tomorrow morning you wake up, you're going to be leg down, head up again. So it does not help at all. So it's very important that the stockings you can wear, but it does not cause any effect. Yeah.
DVT, is it a prophylaxis for DVT if you say after knee replacement for that using stockings when lying down?
Yes, that's a different matter. Because when you are, say, undergoing surgery, you normally have to wear the stocking early, especially when you're undergoing anesthesia. Because what's going to happen is, I was involved in this study looking at the venous flow. So you imagine that when I'm lying down, I put a probe on the common femoral vein. I can actually measure the venous flow velocity. So say the venous flow velocity is say 50 centimeter per second. Now, when I put a patient on the compressive stocking, when I measure the venous flow velocity, it actually increases to twice. May it goes up to 75 or 100 centimeter per second. So by wearing stocking itself, you actually improve the venous flow in the deep vein. Why? Because you are making the muscle more sort of compressed, and also the diameter of the deep veins are actually getting smaller. So that is actually increased by reducing the diameter, you actually increase the velocity of flow. So in that way, you find that it actually prevents stasis.
I see. Okay. The any other questions from the floor?
Yeah, can I just add something? I mean,
Sure.
like what you said, we do see a lot of elderly patients coming in with this leg swelling, and then you convince them that the kidney function, liver function is normal, the heart function is normal, and sometimes they are still not satisfied with the explanation, and some of them will go and buy diuretics off the pharmacy over the counter. We do see a lot of patients like this. So I mean, I guess it's a fairly underdiagnosed problem, venous stasis. So I mean, and some patients actually swear by taking diuretics for a few days and all that, it does improve. But I think it's more of a temporary relief. And we've even seen some patients coming in then with renal impairment because they are intravascularly depleted. So I mean, is there any role? I mean, just say like a short use of diuretics and all that, Dr. Liu. I mean, what's your view on this?
Yes, certainly. If you put a patient diuretic, the find this edema actually decreases substantially. But maybe just for a short term. But in the long term, if you were to keep using diuretic, you only decrease the intravascular volume and make the patient more thirsty, pee more, so it does not affect that leg that's swollen. But for a short term, maybe yes.
No more questions. It gives me great pleasure to thank both Dr. Navin and Dr. Liu, I think, for your very informative talks about this very common problem of venous insufficiency. And I would like to thank all of you who are listening in and for those questions that were asked. Now, this is coming on to the most important about claiming your CPD points. Very soon, they will be putting up your QR code. So please get your MMA thing ready just to get it. And with that, I would like to thank all of you and looking forward to next month's SJMC Grand Round. Thank you very much, everybody.